Okay, we're back to our afternoon session. I have to answer a question by Dr. Adib. But what do you do if the patient feels too much burning during the session? If you're talking about chemical peeling, again, no peel need neutralization except for glycolic acid. So we can use simply a cool towel, and that should resolve her burning. But it is not common for patients to have any pain over 10 with just simple pass of lactic or mandelic acid. The other question about carboxytherapy video, hopefully when you attend our next Congress, Dr. Isabel can show one of her videos for you. Okay, now it's my great honor and pleasure to present to you my friend from Dubai, Dr. Rashad Haddad. He's a French board certified and a member of the French College of Obstetrician and Gynecologists. Started his medical career within the academic hospital in Paris and followed that path, becoming a professor. He maintained a private practice in French capital as well as in Dubai and Riyadh. Dr. Haddad was with the first World Physician Group upon formation of sexual medicine, Oxford University in 2007, with the European Society of Sexual Medicine. Dr. Rashad Haddad is one of the pioneers in the new field of cosmetic and regenerative medicine in Europe and in the Middle East, and the first international senior faculty with the American Academy of Aesthetic Medicine in this field. He's going to talk about Optimum vaginal hydration non-hormonal home kit. So please go ahead, Dr. Rashad. I'm not sure I can hear you, Dr. Rashad. Can you please raise your voice? Maybe you're muted. Can you try again, Dr. Rashad? We can't hear you. Yeah. Let's try again. So while we're waiting for Dr. Rashad to try to fix the connection, is Dr. David Sarafin available? Dr. David Sarafin? Okay, let's try to answer some of your questions while we are waiting for the problem to be resolved. So we're open for any questions.
Ayman?
Yes.
Do you hear me? Tell me, Ayman, your opinion about using CO2 lasers in bleaching genital region.
That's a great question. Oh, now I can hear you. This beautiful voice come like Beethoven. Let me answer Dr. Biot very quickly. I always say to everybody, you can kill a fly with a little zapper, $2 zapper from the dollar store, or with a nuclear weapon. You can choose how do you want to kill the fly. We have this $1 to bleach the patient with less possibility of problems. CO2 laser and erbium laser we use as aesthetic surgeons in the face because we want to get rid of large pores, we want to resurface fine lines, we want to have a smooth facial expression. But if you use it just to erase the epidermis and part of the dermis in case of CO2 laser, I think you are taking so much risk if your patient is not very well prepped. Remember, most of these patients who come with dyschromias are typically skin type 4, sometimes 5, and using ablative lasers to resurface the area. If the patient is not very well conditioned for the melanocytes to have a complete blockage with tyrosinase inhibitors, at least 4 weeks for skin type 4, 5 weeks for skin type 5, 6 weeks for skin type 6, you're risking PIH, you're risking worsening of the condition. And the last thing you want is to have somebody coming with a tea and make them an espresso after 3 months from the PIH. So I am not very big fan of using lasers for bleaching. I know that laser companies, when they sell you a $100,000 machine, want to tell you that it does this, does this, does this, you can do this, you can make your neighbors less noisy, but it is not my preference. I have it, I never use it on the genital area, I only use peeling. So I hope that answered your question, Dr. Biot. Rashad,
thank you very much for your answer.
All yours.
Thank you.
Go for it.
Thank you. I will share my presentation. Okay, you see the presentation? Okay.
Yes, we see.
Okay. So good afternoon again, because you didn't listen to me. Thank you, Dr. Attar, my friend and international senior in cosmetic medicine in general, and long-time friend for more than 15 years, for the invitation. Today we will talk about something new to treat and to handle an old and everyday problem, which is the vaginal dryness. So there is an optimum vaginal hydration with non-hormonal home kit. My name is Rashad Haddad. I am fresh board OBGYN and the practice mainly in aesthetic and regenerative gynecology in 3 cities, Dubai, Paris, and Riyadh. What is the problem we are talking today? We will talk about vaginal dryness. The vaginal dryness has, all doctors know, and in particular gynecologists, has a prevalent impact on the quality of ladies' life. We know that roughly 1/3 of the female population, they will suffer at least one time in their life of this vaginal dryness. The problem is, in many of those women, this vaginal dryness will, all the consequences and complication, it will result in years of discomfort with all the impact on the personal life, on the family and social work. It's different than the vasomotor symptoms of the menopause, that those symptoms of vaginal dryness are progressive and they will not regress with time. 5 to 15% of premenopausal women have the symptom of vaginal dryness. And in the postmenopause, this percentage will pass up to 40% of the postmenopausal women. And with ladies who are under systemic hormone therapy is around 20 to 25% of the female population under oral or systemic hormone therapy. What are the etiology and the pathophysiology? The etiology is mainly related to estrogen. So by consequences, we can detect the result, the etiology and the causes. Menopause or oophorectomy could be surgical or non-surgical. Postpartum, because there is loss of placental estrogen. Breastfeeding due to increase in the hormone of prolactin, which will affect the estrogen concentration, as well as we said, the birth control pills. The pathophysiology, the presence of estrogen will affect, direct effect on the thickness of squamous vaginal epithelium, which will continue to be pink and moisture by what? By the mucus layer, which will enhance the glycogen formation, as well as proliferation of connective tissue and fragmentation of elastin and hyalinization of collagen. This is one part. The second part of this is the effect of Dederlein lactobacilli, which convert glycogen from the vaginal cells to produce lactic acid, which will reduce the vaginal pH to the optimal pH, which is between 3.5 to 4.5, to protect the vaginal wall and vaginal tissue from any infection like streptococcus, staph, coliform diphtherid, and other kind of infection. Postmenopausal change in the vaginal epithelium could be loss of folds, loss of inner lining, as well loss of glandular tissue. While in the premenopause, we will have decrease in the fold, there will be less muscular coat, and inner lining contain still certain amount of collagen. The genitourinary syndrome of menopause is related directly to low level of estrogen as well as other hormone in the female body, which will lead to burning and irritation in the vagina, dryness, discomfort, dyspareunia, which is pain during intercourse, as well as other urinary problem, hormonal imbalance disorder related to sex hormones. What are the important points in the anatomy? We all know that the vaginal epithelium, it consists of 3 cellular layers: the superficial one, the intermediate one, and the basal. And here, if we notice, the basal one, it's the storage of glycogen under the effect, the direct effect even, of the estrogen. With high level of estrogen, all level, the 3 layers of the epithelium will be thickened as a result of glycogen storage. And as we said, glycogen will convert to lactic acid to maintain a healthy pH between 3.5 to 4.5. And we see the difference from left and right, that all the layers are affected with the low estrogen, and especially the superficial one. So with low level of estrogen, all layers become thin and atrophic. Vaginal pH became more alkaline, resulting in alteration of the normal flora, and it will increase the susceptibility of infection because the tissue became fragile and there is no this defensive pH against any infection. Vaginal dryness is mostly due to vaginal atrophy. And vaginal atrophy, it's where there is estrogenized status opposite to the low estrogen status after menopause or after other reason of low estrogen secretion. If we go to the histology,
عاجل بدء الحصار الحربي على إثيوبيا لاحتلال أرض السد وعاجل جدا الجيشان.
Okay, if we go back to the vaginal histology and we look to the premenopause, there we will see the well-estrogenized epithelium, multi-layered with good blood supply and superficial cells rich in glycogen. Although thickness on the left side became very thin after the menopause due to the deficiency of estrogen, which will lead to vaginal atrophy and marked thinning of the epithelium with reduction of blood supply and almost absence of glycogen. What are the symptoms? The symptoms are vaginal atrophy, which is inflammation of the vagina caused by the thinning of the tissue due to hormonal irregularity or menopause. Other things, vaginal dryness, it's related both, but let's have to separate at least by definition. Vaginal dryness is decreased and loss of lubrication in and around the vagina, with all the consequences of absence of pleasure, discomfort, till pain. So vaginal atrophy is often associated with vaginal dryness. Sometimes other symptoms are added like soreness, postcoital burning, dyspareunia, as well burning leukorrhea. All are related to hormones and pH. What are the therapy available on the market? Of course, first-line therapy for women with vaginal dryness will try to include non-hormonal vaginal lubricant and moisturizers. And women should be encouraged to continue their sexual activity. Lubricant, moisturizers. Let's see what is the difference between the two words. Lubricant may relieve the vaginal dryness and discomfort during sexual activity, providing short-term relief from vaginal dryness and dyspareunia. So it's on-spot treatment. While the moisturizer are intended to be used primarily for the relief of vaginal dryness on a day-to-day basis to provide comfort and offer long-term benefits. So it's continuous treatment. Here we have different effects. Lubricants are temporary measures to relieve vaginal dryness during intercourse. It's short duration action and limit their usefulness as non-long-term solution. Should be applied frequently for continuous relief and required application and replication before any sexual activity. The problem with the lubricant, they don't allow spermatozoa to move because spermatozoa move very well in a water-based solution and cannot be mobile freely in an oil or lipid solution. So lubricant are not a solution for a couple who desire a pregnancy due to the oily or lipid base. On the other hand, we have the moisturizer. The moisturizer claim to moisturize the vagina and provide more than this transient action. It should provide long-term relief, but are not so efficient like the lubricant during sexual intercourse. Most of the moisturizer have a main ingredient, which is hyaluronic acid, because of its hydrophile property of hyaluronic acid. There is a lot of study done about this. As we know, 1/3 of the ladies, they complain from these symptoms. So we choose 4 clinical study we are using only hyaluronic acid solo, and the other 4, they use it with MSM, with vitamin B, with lecithin, liposome, and other. All the studies that we are looking now, they use the same percentage of hyaluronic acid, which is 1%, to be comparable when we talk apple to apple. So the first one, they study only hyaluronic acid 1% gel for 8 weeks. And by vaginal health index and visual analogic scale, they look at it for 8 weeks and 3 times weekly. At the end, they found that almost 50% of the cases have been relieved from the symptoms. And this is an excellent result using hyaluronic acid solo, and the degree of patient satisfaction at the end of the treatment is high when we are talking about 50%. Here I use 2 terms. I want, if you allow me, to talk about it, which is vaginal health index and visual analogic scale. Just a reminder. So the vaginal health index score, when we talk about this, is a tool that evaluating 5 parameters: vaginal elasticity, vaginal secretions, vaginal mucous membrane, and vaginal hydration. This will allow us to obtain a final score defining the degree of atrophy in the genitourinary tract by assigning a single score to each parameter: elasticity, secretion, pH, mucous membrane, and hydration. The visual analog scale, like we all know about the pain scale from 0 to 10, is a measurement instrument that tries to measure characteristic or attitude that's believed to range across certain value that we cannot formulated, okay? So it's often used by epidemiologists or clinical researcher to measure the intensity or frequency of different symptoms from the patient perspective. So visual analog scale from the patient perspective. We will go back to our studies. Again, another study compared only solo hyaluronic acid gel versus topical estrogen. And there is two studies. One of them, they found that it's almost equal effect on the relieving of vaginal dryness symptom. And the other one, they found that the hyaluronic acid is superior to estrogen on relieving the symptoms. The third one, again, versus estriol gel for 12 weeks, the dyspareunia and sexual function were examined through a visual analogic scale. Both treatments were effective, even though there is mild superiority in this study of estrogen cream over the hyaluronic acid cream. The second group of product, which is the hyaluronic acid 1% associated with vitamin A and E. Vitamin E is an old treatment of vulvovaginitis. We have done an analysis in 4 weeks, and the result confirmed that the same result as we study only hyaluronic acid solo. If you remember, the symptoms were relieved in 50% of patients when we use hyaluronic acid alone. Here, when we add vitamin A and E, we get the same result in both studies: decrease in vaginal dryness, decrease in dyspareunia, decrease in vaginal inflammation. Another study, the analysis of by visual analog scale 4 times for 3 months. The vaginal dryness decreased from 78% in 4th visit. Dyspareunia from 4.8 to 1.7. Burning from 5 to 1.5, roughly. Stronger rather than gel with only hyaluronic acid. If we remember there, it was roughly 50% of patients relieved from the symptom, while when we add other products to the hyaluronic acid, we have relieving of symptoms in roughly 80% of the cases. Optimum vaginal hydration, the non-hormonal kit. So, what is this non-hormonal kit? It's an innovative medical device which combines the lubricating and moisturizing action with an innovative mechanism of action. So we need the lubricant for the immediate effect. We need the moisturizing for long-term effect in a different mechanism of action. So here we combine both action. We are using hyaluronic acid with phospholipid gel in the last product. There is the classical action of immediate lubrication due to phospholipid. There is the moisturizing action due to hyaluronic acid. And the innovative point of mechanism is the lubricating action due to the presence of liposome. What does that mean? Liposome are those tiny bubbles made of some material of cell membranes, the phospholipid. What are the advantages that we have with liposome? The phospholipid in the liposome membrane permit to enter the vaginal wall which is permeable to them. So they enter deeply in the vaginal wall where they can release the content of water. How the mechanism it go? There is high affinity in the cell membrane, hyaluronic acid with the liposome. They will relieve the hyaluronic acid and liposome, high absorption from the cell membrane, and they will lead to hydration to the deep mucosal layer. First point is different from other moisturizer for the deep hydration due to the innovative mechanism. Has a long-lasting hydrating effect. Liposome have a double action. It penetrates in vaginal wall, releasing deeply water. That's what we need, the deep action. Phospholipid responsible on lubricating effect in vaginal lumen, superficial action, which is during intercourse what they needed immediately. Different from other products that they are microdispersed in water. So the absorption is higher and the penetration to the deep tissue is faster. Lubricant effect of this new home kit, phospholipid make the new home kit gel more lubricant than gel with only hyaluronic acid. Lubricating component is microdispersed in a water solution containing arginine, which the arginine by itself will support the sperm motility. So it's lubricating, maintaining the same characteristic of water gel because this lubricating phase is completely dispersed at nanomolecular level where the spermatozoid can move freely in vaginal hyaluronic gel. Point 2, the new home kit is a fertility friendly gel. Target population are not only pre, around, or postmenopausal women, even in young women with infertile age with transitory vaginal dryness for any reason. Point 3, and this is important for me, the new combination is involved in cell repairing mechanism. The combination of gel is increasing repairing mechanism of epithelial cell. The wound distance is shorter after application of the new gel 1% concentration. It could be very useful in treatment of vaginal erosion, which are the main cause of dyspareunia, and I think one of the most commonest cause of dyspareunia. So what are the indications? Vaginal atrophy, vaginal dryness, vaginal burning, vaginal itchiness, and menopause. Wide indication. Another 5 indications: vulvovaginitis, dyspareunia, vulvodynia, chronic inflammation, as well recurrent vaginal inflammation. The non-hormonal kit has double mechanism. The first one, hyaluronic acid, with the superficial moisturizing short time action. It has an adhesive action. It protects the liposomes, keeping them to contact with vaginal wall. So the liposome and the hyaluronic acid will stay in the vaginal wall to give this superficial moisturizing. And the other mechanism by liposome, which will penetrate inside the vaginal mucosa, which is differently from the hyaluronic acid. They will go deeply in the vaginal wall where they will release the carried water. Thank you very much for your presence and your listening.
So any questions for Dr. Rashad? There is a question from Dr. Adib. What is the dose in recurrent vaginitis? The kit is enough for how long?
First, there is no specific dose because here we are treating the symptoms and long-term therapy. The kit could be enough for a few days because it's a gel with applicator and we can put as much as we want. There is nothing active ingredient. So it's just symptoms relieving with long-term effect to prevent recurrence of those symptoms.
Very good. Thank you very much, Professor Rashad. It was very informative presentation. Now we're going to listen to the presentation by Dr. Dawit Sarafin about reconstructive approach after hypercorrection for the labia minora. Dr. Sarafin is considered one of the first Poland's gynecologists specialized in aesthetic gynecology. In Poland, Dr. Sarafin is well known as an expert in the treatment of aesthetic gynecological conditions using hyaluronic acid filler Nuevia. Dr. Sarafin is also one of the first in Poland specialized in intraoperative laser methods for treatment of vulvovaginal disorders and aesthetic corrections. Dr. Sarafin is the lecturer on current topics and techniques in aesthetic gynecology. He's also a senior member of the European Society of Aesthetic Gynecology and a faculty of the International Cosmetic Gynecology Congress in Dubai. So let's put Dr. presentation, please. A question for Dr. Rashad again about the use for this kit. Can we get it in Dubai? I think Abbott company supplied this in Dubai, if I'm not mistaken, Dr. Rashad.
Yes, absolutely. It's not yet in the market, but it will be in the coming few days, I think. It's registered and it will be in the coming few days. But they can contact me. I will guide them where to have it if they wish. Anybody want, most welcome.
Perfect.
You know.
So while we're waiting for Dr. Is it the higher gel? Is it the higher gel?
No, it's not. It's not. It's not higher gel.
It's not higher gel. It's something different.
Something different.
Yes. Any other questions while Dr. Sarafin is landing? He's still in customs, so we're waiting for him. I guess we're still waiting, so waiting for more questions. Any questions for Professor Amr about vaginismus, about, yes, Dr. Hassan, please.
I'm sorry, I'm just, I don't have enough experience in vaginismus, of course, but as you know, Dr. Attar, you give us a lecture about injection of botulinum in 3 doses in the labia majora. Of course, I don't have such experience, but now I see Dr. Amr Saifuddin have another approach.
No, actually, I never injected the labia majora. I am a little different from Dr. Amr in my approach because I don't ever use local anesthetic like Amr inject local anesthetic, 4 cc anterior vaginal wall, 6 cc's posterior vaginal wall, 2 cc's on both sides. I always stay to the basics of embryology. The vagina, as all we know, originates from the urogenital sinus, give us the upper 2/3 where it's devoid of nerve endings, so there is no sensation whatsoever. The hymen is just a mark between the upper 2/3 and the orgasmic plateau, or the lower 1/3 of the vagina. So my technique, which I'm going to show later in a video, is injecting my botulinum toxin at 3 o'clock, 4 o'clock, and 5 o'clock, at 9 o'clock, 10 o'clock, and 8 o'clock above the hymenal ring, upwards and lateral, without local anesthetic, because the patient doesn't feel it. And actually, I have a video when I'm doing it. I don't use local anesthetic like Dr. Amr do. And I don't use dilators as well, because in my opinion, if the patient responds according to a certain dosing regimen, vaginismus have 4 classes. Actually, to Dr. Pasek in the United States put number 5. Number 1, when patient have a little discomfort, we only use 50 units divided in 2 doses on each side at 2 o'clock and 4 o'clock. We put 25 units on each side. Class 2, when there is significant discomfort, but still the patient can manage to have an intercourse. And in this case, we usually inject 100 units, 50 units on each side, divided at 20, 10, and 20 at 3 o'clock, 2 o'clock, and 4 o'clock. At stage 3, when patient is really suffering, crying, but the partner is not, it's like a rape kind of thing, but the partner is not stopping. And in this patient, we still do it under fully awake, no anesthesia whatsoever, no sedation, no hospital. And we inject 150 units. We inject 25 units at 3 points, 3, 4, and 5 on the right, 10, 9, and 8 on the left. If the patient is class 4, which is like hitting a brick wall or impossible penetration, these are the cases where I get my anesthesiologist to give propofol, and 5, when the patient attacks the doctor or have diaphoresis, tachycardia, palpitation, any systemic manifestation, all these class 4 and 5 should be done under sedation. And in this case, we inject actually 200 units. So we inject 100 units each side. Most of the cases, I would say, and at least in my limited experience of few years, respond by changing from 5 to 3 or from 5 to 2. And all what you need to do is to bring them back and repeat the process after waiting a full 2 weeks for the botulinum toxin to have a full effect. I don't see a necessity or a need for using dilators, although Dr. Amr used this, but in my practice, I never utilize that. Because once the muscle is relaxed, you cannot have a spasm. You cannot have this involuntary spasm. And you have a very high success rate with this technique. So that answer, I think, my question to you, Dr. Hassan. Another question. The Botox injection,
Thank you.
You're welcome. Is only once effective for how long? That's a great question, Dr. Majid. us plastic surgeon, cosmetic surgeon like me and my wife are very lucky because I practiced since 2002 in the United States. My wife practiced now for like about 8 years. And aesthetic Botox will be lasting about 4 months because of the sprouting of the nerve endings of the at the motor end the plate. That necessitates us to repeat the treatment every 3.5 months, 4 months. In case of vaginismus, it's a totally different story. You guys are not as lucky because you're not going to get that rich from doing that treatment. Why? Because once you break the pain cycle that Dr. Amr showed in his slide of 6 stages, it's exactly like going on vacation. Now we are, me and my wife, enjoying this beautiful scenery in Aruba. I'm too lucky. So this is what I see every morning here. You see? So Aruba is beautiful. I always want to go to Aruba. And it's the same like sex. If sex is beautiful like Aruba, you always want to go back to this experience. If sex is horrible, then you don't want to do it. So once you break the cycle, you only need to do it once, only one time, and the problem is solved. Once patients have orgasm, have beautiful experience in the intercourse, the problem of vaginismus should be solved. Okay. Any more questions? Again, we are still waiting for Dr. Sarafin Ahmed. Should we proceed? Or
No. I'm here for the last 5 minutes.
Oh, I've been looking for you, my friend. Oh, look at the elegant, beautiful David Sarafin. Welcome. Okay.
Hello, sir. Hello, sir. Thank you so much. Thank you. Yeah, unfortunately, I'm not in the paradise as you. I